Good afternoon. Welcome to today's Wisconsin Health News virtual event on what's next for digital health. My name is Tim Stum. I'm the editor of Wisconsin Health News. Thank you all for tuning in. We have a wonderful panel of speakers with us today to talk about a very important topic. I am thrilled to introduce Coreen Dicus-Johnson, CEO of Network Health, Rachel Robinson, president of DotCom Therapy, Laura Mitchell, CEO of GrandCare Systems, and Dr. Margaret Paulson, Medical Director for Mayo Clinic Health Systems Advanced Care at Home. Before we get started, I want to make sure we thank our very generous sponsors of the Wisconsin Health News virtual series. These virtual events draw healthcare leaders from across the state for these important discussions and truly would not be possible without their generous support. So a huge thank you to Advocate Aurora Health, AARP Wisconsin, Anthem Blue Cross and Blue Shield of Wisconsin, Gundersen Health System, Husch Blackwell, and WPS Health Insurance. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you are not yet a subscriber, I encourage you to sign up for a free trial. You can sign up on our website at wisconsinhealthnews.com or through the event evaluation, which we'll email out after today's event. An extra thanks today to AARP Wisconsin, today's featured sponsor. We are so grateful for all of their generous support. And it looks like here to say a few words is new state director, Martha Cranley, who has been on the job, I think, for a matter of hours at this point. So Martha, thank you so much.
Oh, thank you, Tim, and thank you to the Wisconsin News Network. We're so pleased at AARP to be partnering with you and bringing these kind of panel discussions about really important topics to our members and to the rest of the state as well. As Tim mentioned, I'm the new director for AARP Wisconsin, happy to be joining the team here, and really happy to be a part of the introduction to this really vital conversation. I know for our members, we've been a big supporter of telehealth and because it increases access to healthcare, right? For our members and for others who are in rural parts of the state or who have transportation challenges and can't get to specialists as well as just the regular doctor. We also love that it increases the ability for caregivers to be a part of those meetings. I think we all found out how vital that is during COVID when we couldn't have somebody with us at the doctor's office, for example. So these are all super important topics. We're excited to be a part of this conversation today. And this is another reason that AARP is also really interested in expanding broadband and access to digital services, not only for our members, but for everyone in the state that needs vital services that can, as we've now understood, be able to be delivered this way. So thanks so much for including us. We're proud to be partnering with you all in this, and I look forward to a really great panel discussion.
Excellent. Martha, thank you so much. And thanks again to AARP Wisconsin for all of your very generous support. So we are focused today on what's next for digital health. Digital health solutions, including telehealth, have as we've already talked about, taken a giant leap forward during the COVID-19 pandemic. But what technology is here to stay? How can remote health improve care? And what do patients want most? Also, how's this all going to be paid for? We've assembled a great lineup of panelists to examine these issues and more. As always, our time is limited, so I'm just going to dive right into the questions. And Coreen, let's start with you. Can you just briefly talk about, what is Network Health's digital strategy as a health plan, as an insurer? What type of digital health solutions are you most focused on right now and also going forward? I mean, where's the biggest impact going to be made from digital health?
So we've always had a telehealth strategy prior to the pandemic. And quite frankly, we really believed that as telehealth became a substitute for in-person care, that we would see this grow and continue. What's been very interesting is that we've seen some significant declines. Now, that's not redirecting our efforts. Quite frankly, it's invigorating our efforts because we really look at this as an omni-channel approach. We need to be really smart about how we look at digital health, how we look at telehealth, and all the different technology that we are deploying. And we do it in a very purposeful and meaningful way in terms of piloting. We we piloted a program with GrandCare systems in the middle of the pandemic related to our Medicare patients who are suffering from isolation, and how we were able to get them access not only to their physicians if need be, but to their family, and to kind of help with that regard. We've been using digital health for diabetes for years to be able to have both in terms of what does it mean for those applications for individuals in terms of managing their disease, and also working with their physicians. We actually piloted two different approaches to kind of see the efficacy of each one so that we could go forward. We have several different approaches in terms of how do we support our members for mental health. That's probably one of the areas where we saw the biggest increase in services that has not dropped. And I really think that from an expansion perspective, that's going to be the place. It was a game changer in terms of being able to support the mental health needs of our members. And quite frankly, I think it's going to be the thing that's going to solve for, in many instances, some of the worker shortages and related to mental health professionals. So our approach, like I said, is omni-channel. We will design products and that treat it as such, so that we're not creating additional barriers to care by how we design our insurance products, but it will continue to evolve as the adoption continues to evolve.
Thank you, Coreen. Laura, you work with Network Health along with some others in Wisconsin and others across the country, and even in some other countries. Can you just briefly tell us what is GrandCare Systems? What do you guys do?
Yeah, so thanks for having me today. First of all, I'm honored to be on such an esteemed panel of women. GrandCare is a touchscreen-based solution that is placed at point of care, and the touchscreen sort of acts as a point of engagement and a source of information for the person at home. So it acts as a source of, it's time to do this, their daily schedule, communication, access to family members, a HIPAA compliant video chat, as well as, weather reports and things like that. But meanwhile, there's a variety of sensors that can be placed around the home. So telehealth devices and activity monitoring sensors that are reporting to the system, and then engaged family and providers can set up rule sets that alert them if something seems wrong. So a red flag, if someone's blood pressure is out of range, or if they have a significant weight gain and they have congestive heart failure, or if they simply didn't get out of bed or didn't access the fridge at mealtime, things that could indicate that there might be a potential situation.
Excellent. Thank you. We will come back to you, Laura. Rachel, can you just tell us, welcome, thank you for doing this. Can you just tell us a little bit about DotCom therapy?
Yeah, absolutely. And thank you again, Wisconsin Health News for having us on. So I am the president and founder of DotCom Therapy, and we provide pediatric teletherapy services. So that's speech therapy, occupational therapy, and mental health. And we do so by partnering with school systems, health systems, and then health plans to ensure that we're able to provide access to kids across the country, despite their location. So DotCom Therapy's mission is just to make therapy available to everyone, everywhere.
Excellent. Thank you. And Dr. Paulson, thank you for being here. You had Mayo Clinic Health System's Hospital at Home program. Can you just briefly tell us what that means and what this entails, and where this program is currently offered? Dr. Paulson, I think you're still on mute.
Thank you so much. Thanks for having me. It is a delight to be here today. So yeah, back in 2019, our Mayo Clinic CEO, Dr. Ferrugia, was thinking about the 2030 vision for how patients would want to be cared for. That was pre-pandemic. Things certainly went warp speed with all the changes. And we launched our Hospital at Home program 6 months later. Dr. Ferrugia recognized that people want more personalized care in their homes, wherever they reside. So we launched a virtual hybrid hospital at home model, which is a bit different from the traditional hospital at home, where doctors would go to patients' homes in cars. We recognized that was probably a little bit inefficient. And now with the power of technology, you can be at the patient's bedside in an instant. So we have a centralized command center on our Jacksonville, Florida campus, where they care for patients in the Jacksonville area, but also coordinate care with our home health team and field team here in Northwest Wisconsin, as well as our Mayo Clinic Arizona campus. So it's a pretty innovative model. Our patients have really enjoyed it. And yeah, I'm the medical director of that. And it's been such an honor to serve patients in this unique way.
And Dr. Paulson, thank you. Let's stick with you for a little bit. What has the pandemic, what have the past 2 years meant for this program? Like where are things now?
Yeah, it's been incredible. So, we were early. Before the pandemic, there was only a handful of programs doing this in the country. Now with the CMS waiver, which allows us to care for patients in the home and receive reimbursement, there are over 200 programs around the country. So we've been doing this not quite 2 years. It's been incredible for our patients here in rural Wisconsin. At the height of the pandemic, we were routinely sending patients across state borders to get care because we just didn't have beds. So to provide immediate access in their home was just incredible for these patients.
And what has Coreen mentioned how they've seen a network like many others have seen across the country. They saw an initial spike in telehealth and then things started to decrease. What have you seen with the advanced care at home program as patients are more comfortable going back to hospitals and clinics? Has demand for it, been impacted?
Yeah, I think it depends on the hospital at home program itself. But for us, our hospitals were full even before the pandemic. So during the pandemic, now our demand continues to be robust. So this has been an amazing offering for patients who would otherwise have to go elsewhere to receive Mayo Clinic level of care.
Great. Laura, what about you? What have the past 2 years meant for GrandCare?
Yeah. So, the past and before that, we've been sort of towing the line of technology is a good thing and it can help engage the patient in their own care, but also engage multiple family members and providers to provide true patient-centered care, even if they're remote. So we've been sort of doing this for 16 years. And during the pandemic, it suddenly hit that not only were people having to stay in their own homes so that they were being forced to deploy technology if they wanted to remain connected and engaged, but also, people didn't want to go into the hospital because, that's where all the sick people are. So, when you think about it, we're using technology to go back in time to the time where we provided patient care at home. We're just utilizing technology to be there, and we don't have to be there face to face. And providers can see a lot more people in a shorter period of time without that windshield time, also without particularly rural and remote patients having to find transportation to get to the hospital and potentially be infected when they're there. So we've seen a huge shift in acceptance. And also we have, just yesterday, I was talking to a disability service provider who has 26 positions that are yet to be filled for staffing. So they are really in need and being forced to utilize technology and to embrace technology to really accelerate and amplify their existing staff.
And do you see this continuing? Have you seen any decrease in demand as the pandemic wanes going forward?
I don't think that you could put the genie back in the bottle in a lot of ways. And I think people are getting used to being able to be served at home and do a visit at home. It's so much easier. And a lot of times you don't need to go in person to be able to talk to somebody and discuss what the plan is. It's also a great way for the doctors and providers to remain omniscient. You go to a hospital, you go home, and you go from omniscient to totally blind as a provider. And so now they're going to be able to be engaged in their, post-discharge instructions. Here's how, and be able to engage so that they don't see them back at the hospital. So I do see that people are seeing really positive results. And especially for those who may not want an in-person caregiver in their home, or maybe not want them all the time there. I mean, obviously GrandCare doesn't brush their teeth or take them shopping. So it's, there are definitely places that people need to be engaged, and the human aspect will never be completely not part of it. But there are certain aspects of it which humans don't have to do. Like, we don't have to physically call and remind someone to take the medication. They can be reminded to do that with technology and other aspects where they can be involved and engaged in their own care. And the humans can just be part of that connection, but not necessarily have to take part in all the monotonous work.
Great. Rachel, what about you? What has these past 2 years meant for DotCom therapy?
Yeah, it's been pretty wild. So DotCom therapy has been around since 2015. So we've obviously been a big supporter of the telemodel for a long time now. And pre-pandemic, if you were to ask me kind of what is holding you guys back from really being able to grow, and it was tele-adoption. I think I'm hearing a lot of the same from everyone here on this panel. I'm at the American Telemedicine Association, and it's a similar kind of thread of conversation that's going on. And that, as bad as COVID-19 was, I think it sped up tele-adoption and innovation by years, maybe decades, because all of a sudden people were forced to try their hand in tele and saw how easy it was to use, how much easier it made to access services. And it kind of put the patient back in control of kind of choosing who they choose to see for care.
Great. Coreen, you kind of alluded to this already in your initial remarks, but do you have the kind of rosy view that they have, and in terms of, what this future is for digital health?
So I'm a little more cautionary, and while I believe that there's absolutely inroads, and just as a quick aside, as a former hospital president, I implemented a lot of telehealth. A lot of it was physician consults and other things to help because there's access issues. So there's clearly access problems, and quite frankly, telehealth was the great substitute during the pandemic. Where I'm cautioned is a couple of things. First of all, I don't think we should use the pandemic as to overgeneralize what the future will look for. And the other thing is I think the jury's still out in terms of, is it in lieu of, or is it a complementary approach to providing care? There was a recent study by the University of Michigan. They have an Institute for Healthcare Policy and Innovation, and they did a very in-depth study that had time frame pre-pandemic and during the pandemic, and they really looked at kind of what is the future for this and adoption and things. And there were some aha moments for me, even in terms of how I previously thought that telehealth could solve issues, for example, rural issues and things. And one of the things that this study brought out is broadband. The access to, broadband is a limiter here. Access to interpreters as part of it. Now, a lot of telehealth organizations have that as part of their approach, but there are some things that telehealth can't be the full substitute for. So our approach is, the way I'm looking at it, is it's got to be complementary. I'm going to go back to that omni-channel approach. I think that one of the things that we have to be mindful of is that it doesn't increase costs in total, that we look to find ways that expanded access lower costs over time. We won't see it right away. We may have to spend a little bit in advance, but as we can bring care closer to people and reduce the barriers of why people go and get care, like travel, time away from the office, things of that nature, we start to reduce that friction. There's an opportunity but the question will be, will we just have higher costs, or will we have better outcomes and longer term over costs? And I can tell you that this issue is being looked at as we speak. On April 21st, there was a watchdog paper that came out, and they're estimating that without further expansion, Medicare over the next 10 years will spend $25 billion on telehealth alone, which is great for access. But the question will be, what is that, just additional cost, or are we going to be lowering costs in total? So I don't know the answer to that. But I'm going to suspend disbelief in the sense that this is, that it's not a good thing, that you are mindful of these, you build guardrails. And I think the approach that we'll take going forward is we'll be looking at value-based approach to how we contract. How do we look at, again, that omni-channel about we're going to make things available to you as our insured, whether it's best for you to go televisit, in person, some digital monitoring. We'll start to meet people where they're at in a different way with these technologies, but we have to make sure that we're putting some guardrails on it as well. So I am cautiously optimistic about the future of telehealth.
Great, thank you. Laura, what do you think about the cost question? I mean, do you think that digital health solutions have moved the needle yet on lowering healthcare costs? Are you confident they will? I mean, what are your thoughts?
Yeah, so I think that they will. I think that we're still in the early days. I mean, the cost of equipment will obviously come down, just like in the way that computers started out as very expensive and then they came down. I mean, when you think about the banking industry in the 80s and you think about when they introduced computers, it was a huge hassle. It was a process change. It was a lot of education and it was a huge cost. But at the end of the day, we knew that despite those learning challenges and the curves, that it was going to help, banking in the long run. And of course, those who did not deploy technology are no longer in business as far as the banking industry goes. I think the same is for this. I absolutely agree with everything Coreen said. And I think that technology is just one critical piece. Technology should not run any community or organization. And those who think that it's set and forget will not survive. It's got to be in the same way that network health has care managers that sort of help deploy the care plan. I think there'll be the same technology care managers that sort of seamlessly, and education is huge. If you don't have buy-in from all of the staff from top to bottom, actually, if you don't have buy-in, it won't succeed. You have to have the staff really utilizing the technology, learning how to use it, and it'll be a learning curve. And there will be some costs associated up front. I think obviously Medicare has to come in and supplement some of the actual technology costs, not just the processes, but the actual physical cost of the Bluetooth blood pressure device and the physical cost of the touch computer, because those are the difficult points, as well as the broadband access. That is still a sticking point. We even have like pucks, MiFi pucks with, Verizon or AT&T, and still we're having connectivity issues out in the rural, remote areas that really can't get any sort of connectivity. So that is a definite problem. And those are typically some of the most highest risks patients as well.
Thank you. Dr. Paulson, what kind of results are you seeing so far from the hospital at home program? I mean, I know it's early on, but is it decreasing costs yet for Mayo? Does it have the potential to? What do you think?
Yeah, the cost question is a great one. And the hospital at home literature is actually filled with great studies about cost reduction. So if you look at our European colleagues, the Australians, they've been doing this for a few decades and the cost savings are clear there. In the US, it hasn't been as new, or it hasn't been as widespread. So the cost studies aren't as robust. But colleagues on the East Coast, they have shown cost reductions in randomized controlled trial as well. So that is super exciting and promising for value-based care.
Great. So Coreen, a big part of this, of course, is how is this technology going to be paid for? There are some that have argued that virtual visits should be the same as in-person visits, as kind of we're talking about, it's been talked about so far today, that it's important to take in account the upfront cost of this new technology. How do you see network health approaching this in terms of payments?
Well, I think initially we've had a differential in payments for virtual versus in person. It's fascinating because in preparation, I dove into the studies, and I think the studies are mixed in terms of results, in terms of cost related to an in-person visit versus a virtual. And what was also interesting, it's also, and if you think about it, it's from a patient perspective. It's if they've got the technology and the broadband, the cost in terms of their expenses to get there, whether it's these days gas, time away for work and all those things, obviously it's a win. And so, but from the payer standpoint, when we look at it, we're looking for efficiency. So one of the things that we're going to look for is, if you have a virtual visit, are you going to subsequently have a follow-up visit that, quite frankly, for the same diagnosis, such that instead of having one in-person visit, now you have two. And so it's not just the cost of the unit of actually going to that particular, whether it's virtual or in person. We have to look at what is it now going to cost to take care of whether it's a urinary tract infection or something along those lines. So the answer is, right now, our approach is that we have a differential in payment between a virtual visit and an in-person visit. I think the future in terms of what that's going to look like as coding comes and changes happen with Medicare, I don't know the answer to it. I think that we're going to have to look at efficiencies in healthcare as it relates to what that unit cost looks like. And we need to be looking for, yes, there will be upfront costs associated with the individual, the technology and things of that nature. And I think the industry did a great job of leveraging Epic and other things to be able to make the technology cheaper to be able to do it. But I don't have an answer about the future, because I think that we're going to be going to value-based contracting as a mechanism to look at how those two complementary types of services will be provided versus a unit cost perspective. I don't know if that entirely answers your question, but I think that's where we're going to be going.
Great, thank you, Rachel. What are your thoughts on this? I mean, in terms of how some of this technology is paid for, is it fair to pay the same for a virtual visit as it is an in-person visit? And what do you see going forward?
Yeah, we've seen kind of a mixed response as we're speaking with health plans as to how they're approaching it. From our perspective, I agree with a lot of the other ladies that are here today in that teletherapy isn't going to be appropriate for absolutely every candidate that comes through the door. And we can definitely sympathize with health plans and, not wanting the redundancy of two of the same visits. And so one of the things and one of the benefits of the fact that we've been around quite some time is we've actually developed a teleappropriateness screening tool. And we kind of see teletherapy as being, I know the term digital front door has been thrown around quite a bit, but it's one step in the patient's journey. And if we're able to maybe qualify that patient before they're seen through teletherapy to see, are they an actual appropriate candidate for tele? If they're not, then let's go ahead and let's get them in to see an in-person provider. All the while creating room for those high acuity patients that aren't good tele candidates to be able to go and see those in-person providers, while also being able to leverage the tele ones for people that are. So I think that's all going to be cost savings. On top of that, when you remove location as a barrier, we all talk about access, but there's also quality that we need to be able to talk about and matching with the correct provider. So, to your point, Coreen, in the beginning, accessing a provider that has the same language as you. If you're living in rural Wisconsin, you may not have that in your community to access, but tele allows us to do that, for you to be able to match with the right therapist that also happens to be convenient. And that's what I see as kind of the power of tele. The cost savings is something that I think we're going to start to see down the line, but we can have a lot of theories about it. And that obviously getting into care faster is a good thing. Seeking the right provider is a good thing. Creating room for in-person for those high acuity patients at a faster rate is a good thing. So I think it's yet to be seen just how much we're going to be able to account for cost savings, but I think it'll be there.
Thank you. Laura, what do you think? What factors do you think need to be taken into account as we figure out how this is all paid for?
Well, I think that telehealth and remote patient monitoring and even just digital engagement so that the patient is actually informed and empowered in their own care is clearly going to lead to better outcomes. When somebody is engaged and they know what their blood pressure is and they know what their goals are and they know which medications to take at what time and the instructions, obviously they're going to be more incentivized to, provide better care for themselves, as well as their family can be engaged in their care. So I think technology, again, I want to be sure that we don't just think that we just throw technology solutions at everyone and wash our hands and decide to walk away. It has to be a piece of the solution, but the technology is only as good as the people surrounding the technology. So, our founder, Charlie, always said, we've got the hardware and the software. And what we do is we empower and we gauge. And the smartest part about our technology is the wetware. So the wetware is whoever's sitting in front of that system and being able to set up the right parameters and rule sets. What does that mean? For this patient that has congestive heart failure, what is a red flag symptom? For this diabetic, what is a red flag symptom? For this person, what do we need to be aware of? If they have petit mal seizures and they're wandering around the apartment, what do we need to be aware of and what are the next steps that need to be taken? So I think the technology should be used as a triage service in that it gets them to the right provider at the right time. So if somebody's sugar levels are beyond a certain point, should that go to who should that go to? Should that go to the cardiologist? Probably not. So who needs to know that information? So if we reduce noise and we can just give the right providers the right information and they know that no news is sort of good news, so they're just being alerted of when they need to take steps, that's going to save a lot of time. It's going to be more efficient. It's going to save burnout because they're going to know exactly what steps need to be taken. And it's also going to be able to provide a sort of care manager that's responsible for the ecosystem of the technologies around this person, as well as their appointments and family and things like that. And it'll help them to be able to navigate them to the right areas, which at the end of the day will save money.
Yeah, Tim, if I could get
please.
A question, I want to reiterate something that Rachel said earlier, and I think it's a really important point. And that is, how do you appropriately stratify where people should go and for what? And I will tell you that the early studies are showing that for people with chronic conditions, which is a lot of what Laura's talking about, telehealth is just a phenomenal way from an engagement to be able to keep them because they've been diagnosed with something, and how do we continue to engage them in their health and keep. But chronic condition, an acute condition as it relates to, I've got something going on right now. There are studies that show that if you don't get a prescription on that televisit, that person's going to show up back into the ED or the urgent care or whatever. So we have to be mindful, and that's why this stuff is in, I know I represent the big bad insurance industry. By the way, we are provider owned and provider friendly. So for those of you, we do make really good holistic decisions about our members, but we have to be thoughtful about those resources. So thinking about the type of care based on the issue of the patient, and Dr. Paulson can obviously disagree, but I think it's not everything is appropriate for a televisit because of the potential of additional costs. Similarly, like they stratify their patients for home, hospital at home versus somebody that needs to be in a true facility setting. So just wanted to get that in.
Thank you. And Dr. Paulson, what do you think about that? I mean, you're also an internal medicine doctor. I mean, what are your thoughts?
So many thoughts about this. Well, first of all, yes, you are correct, Coreen, that not all patients are appropriate for hospital at home. And we have to have a very robust conversation with patients about shared decision-making. Not everybody is comfortable with the risk of going home without immediate access to a crash cart down the hallway. So that shared decision-making is very important. In addition, we need to do due diligence as a healthcare team to select the patients most appropriate for home hospital care, digital care. We do that a number of ways. The first is through a clinical stability screen to ensure that we're taking the right patients home. Obviously, we can't take patients home who need ICU level of care, they need to be in a facility for that. Or if they need a surgery immediately, they need to, have access to the surgeons in the operating rooms. So that clinical stability is essential. Social stability is also essential, ensuring that the patient has what they need at home to heal appropriately. It's a pretty low bar, actually. So, patients are living in their home. That's where they are most of the time. So we want to make sure they have access to electricity so we can use the technology, running water. And this gets tricky, right? Because we've taken care of patients who have contaminated wells. So it's been really interesting when we get in the home then to get a front row seat to what's happening in the home. And often when we get in, we have these ahas like, wow, this is why you keep coming back with a wound infection, is because you have, many cats and they're contaminating your wound. So these are just real life things in the patient's home that the virtual hybrid model makes possible. And then lastly, partnering with the patient and their families and caregivers. It's different in the hospital, right? Where the onus of responsibility is put on the healthcare team, and then the patient, we try to be partners, but ultimately the power balance is a little shifted. In the home, we are guests, and they tell us when to come and go, and we really need to find ways to work together to find the best care for them.
Thank you. So Dr. Paulson, on the payment question, a big payer for your program is the federal government. Can you just give us kind of a brief, kind of status report on where that is? So as you mentioned, a lot of this work was propelled during the pandemic through a waiver from CMS. What's the status of that, and kind of how, what does CMS's continued buy-in, mean for programs like Advanced Care at Home?
Yeah, so the CMS waiver was certainly essential to getting programs off the ground. However, a lot of payers are uncertain about whether the waiver will continue. And so commercial payers often follow CMS. So getting maintained Medicare reimbursement is essential. So right now there's actually a bill in the Senate and the House to continue reimbursement for an additional 2 years. It was set to expire when the public health emergency expires. So the Hospital Inpatient Services Modernization Act is something that, Mayo Clinic has been supporting. Over 100 other entities are supporting, and certainly would add a lot of stability to the regulatory or the reimbursement landscape. So I think that's going to be essential as we look to the future. And certainly, we continue to partner with not just taking care of Medicare patients, but partner with commercial payers too, because that is truly needed to create access for all of these patients who otherwise wouldn't be able to use the home hospital.
Great. So Laura, let's go to you. We've talked about this a little bit already, but maybe you could just expound a little bit on some of these barriers that remain for virtual healthcare. We've talked about this momentum that's taking place. What's in the way of further momentum? Specifically, you work with a lot of seniors, including technological barriers like accessing and using technology. What are some of the barriers that remain?
Yeah, so we work with seniors, but a large marketplace that we've recently gotten into in the last couple of years is the disability market, the intellectual developmental disability market. And the interesting part about that is that there's a lot more reimbursements and grants set up for that sort of care. So we've had an easier time getting reimbursements, not ourselves, but our providers who are utilizing GrandCare to help serve maybe group housing situations or somebody with a developmental disability be independent for the first time. There seems to be more access to funding for that, and technology first states that pay for technology before people. So we've seen already in some studies there that we've been able to reduce staff to patient ratio, but it used to be like one of our providers 1 to 6, and they were able to utilize technology solutions to make it 1 to 20. And so you can see obviously cost savings there. The barriers still remain the same. I mean, and they're pretty simple. I believe it was Ann Tumlinson from ATI Advisory that once said that we have a bunch of Christmas ornaments, but no Christmas trees. And so that's sort of how we view technology at this point, because we have all sorts of ancillary technologies, but we need some standards for integrations and interoperability. Obviously, people don't want to log into multiple places. So it's very important at GrandCare that we have a library of APIs, which we do have. And a lot of times when we're looking to integrate with EMRs, EHRs, medication databases, things like that, or a diabetes management system, it's important that we all have APIs that can connect with each other so that it pushes information back and forth. Just making, it shouldn't be harder for someone to take care of someone utilizing technology. The goal is simplicity. So that is still a barrier. Obviously, internet connectivity, not only the internet connectivity should be a utility that is provided for all. I think in this day and age, you cannot not have internet connectivity and live in this community and thrive. So we need to figure out ways for infrastructure for connectivity, as well as payment towards it. It should be there should be more reimbursements towards that. I also think that there's also the idea of learning curves and utilizing technology and being able to embrace it as a care partner from the bottom to the top. It has to be something that there needs to be more education involved in that. I think I think I mentioned that before, so I don't want to beat that dead horse, but it is definitely something that is a process, and it can't just be thrown in there. It has to be well thought of. How are you going to successfully implement the technology? Who's going to run the technology? It can't just be something that our existing staff members somebody will just take care of it. You've got to designate somebody that's going to sort of take care of it, continuously educate staff on how to use it and be able to respond to it.
And so what about just adoption from the health system in general? A lot of these things, it's not necessarily the technology that's holding us back, right? It's the willingness and the ability of the healthcare system. I mean, healthcare is really big and behind a lot of other industries in terms of adopting technology. Where do things sit with that? What kind of barrier is that right now for some of these digital health solutions?
For healthcare systems themselves, I mean, there's a lot of pieces that happen there, especially in hospital settings. I wouldn't say that, for example, like the GrandCare system, we aren't really designed for the acute setting. We aren't designed for the hospital. We are designed for hospital at home, where we can provide telehealth and things like that. But I will say that our experience, particularly with network health, has been so rewarding. And I just have to say that Coreen really does have a holistic group of staff. They are not the big bad payer that we thought we might be getting into bed with. It has been tremendously rewarding to work together with them, because they truly offer engaging and value-based care. So I think that there are some barriers of getting involved with that, because you've got to make sure that everybody is on board and understands exactly the processes that are taking place. And of course, when you're coming into something like this, you've got a diabetes management system, and you've got a congestive heart failure system, and you've got a medication management system. So it's sort of like pulling all the pieces together. And I think that's going to take some time to figure out.
I think if I could just interject, my history of running the former Wheaton Franciscan Medical Group, adoption is, and Dr. Paulson, keep me honest on this, but if you disrupt a physician's workflow and ask them to go to all of these different places to get information for their patient, it needs to be a part of their flow of how they can provide the most effective and efficient care for the patient in terms of the information. So I love that analogy of we've got a lot of ornaments, but we don't have the tree. And that is, there are a lot of apps, there's a lot of information, there's a lot of stuff out there that have the promise of doing a lot of things. But if it's not incorporated into the physician's workflow or the nurse practitioner or the therapist's workflow, and they have to spend 5 clicking in and signing in and doing stuff, you will not get the adoption. It has to be embedded as part of that. And so the focus going forward, I think some interoperability, you're starting to see a lot more in terms of regulations from CMS, getting providers and payers and all of us to work and look differently about how we communicate is the next, if you will, place where I believe we're going to start to see it embedded in the workflow. We have to make it easy for the physicians to look at this information and act on it. And if we don't, it's not that they're not caring, wonderful people and want to have that access, but there's only so much that they can do in that visit. And for the therapist and the nurse practitioner, only so much they can look at and do. So you got to make it simple.
Do you think, Coreen, do you think that there's a role that policymakers can play in removing some of these barriers?
Well, I think that they already are in this terms of kind of how you're starting to see the regulations and the laws that Congress is promulgating related to getting us all to work better in the sandbox. So I think it is they're mindful of it. I think there's a lot of criticism of CMS and stuff, but they have an innovation center where they're looking to do some of these things. And maybe I'm too positive about things, but the approach is that they start with, certain types of process measures and then it evolves. I think that, Medicare Advantage would be a perfect example of something that started in one way and has evolved. So I think that we're on the precipice of it. The cautionary tale is what I mentioned earlier. So you got MedPAC, you got, I think it's the CBO and a few others that want to study the impact of what this will mean and how do we build telehealth, digital health in a way that we can afford to pay for it. It makes a difference in terms of the outcomes, and it's meeting patients where they are and giving them the ability to have access where they may not have access to, and social determinants of health or health equity. I mean, that's the other part that we have to be very careful about, because we could push this too fast and not have all of the right guardrails in place where we could actually create more inequity by deploying things, for example, a virtual health plan first before, and things of that nature. So we have to be mindful of that. And so I think it's going to be we'll plan something, look at it, see how it works, and then we'll go forward. And I don't know that that's a bad thing.
Great. Rachel, what do you think? Well, what do you think in terms of what type of barriers still remain and what more, if anything, policymakers can do?
Yeah, and I've been keeping an eye on the chat. There's lots of interesting discussions going on in there. And one of them, has been talking about access to internet, and it's something we've all been talking about as well. And before jumping on, I did like a quick Google search and saw the FCC, about 1/4 of rural communities do not have access to high-speed internet, and 1/3 of tribal communities don't have access to internet. So that's the most glaringly obvious problem that we need to fix. I think the good news is there are a lot of companies out there that are working to remedy that. Verizon, I know, is a huge advocate for increasing connectivity in these smaller areas. On the plus side, 1/4 of communities don't have it, but that means 3/4 do. And these are typically the types of communities that struggle to get that brick and mortar care. And so they are able to access our services. And even to kind of go back to when .com was originally started, I did a hybrid approach in rural Alaska, where I would actually be out there for 1 week out of every month. And then the 3 weeks remaining, I would do it all through tele. And they didn't have running water in some of those villages, but they had high-speed internet. And it used to be a time when they used to have to get on a bush plane and go into Anchorage for care. But it's amazing what telehealth has been able to do for them. And I strongly feel like even in very, very rural Wisconsin, that it will have similar effects if we can get these people connected. In terms of policy that I've been watching, and I've also seen it on the chat feature, is state licensure. There are so many times where we'll have a bunch of mental health providers that are ready to be deployed, and we're literally just sitting, twiddling our fingers, waiting for their licenses to get processed. We cannot do our work if we cannot have our license, and that is literally just pushing paperwork through. And so developing those cross-state compacts, realizing that telehealth isn't going away. I think, Laura, you said we can't put the genie back in the bottle. And so we have to make sure that we're developing and reshaping our policies to reflect a more connected US.
Great. So we are quickly running out of time, but in the time that we do have left, I want to ask a concluding question of all our panelists. I want to keep looking forward. What area or areas of healthcare, as we look forward, do you think are going to be most impacted by digital health solutions in the years to come? I mean, what is the future of digital health? And Laura, let's start with you.
I think that the future of digital health is more, I think should skew younger. I think that in the way that we know, our tire pressure levels in our car and oil status and gas and all of that, we know more about our cars than our own bodies. So, I'm in my 40s and I am now, interested in my blood pressure and things like that. And I think that more people should be interested in their own establishing a baseline so that we know what is a red flag. If my baseline is this, then when do I have a fever? And I also think that there's going to be a lot of future in post hospitalization patients. I think there's going to be a big feature of people being able to push all of their medications, all the instructions there, so that they know with the 9 different medications they have to take after being discharged from the hospital, when to take them, directions on, and they can continuously watch those discharge instructions versus listening to them in 10 minutes as they leave the hospital. And lastly, I think that there's going to be a big rehabilitation market. So people that are in rehab or physical therapy, I think that that'll be a big marketplace.
Great. Coreen, what do you think? What areas of healthcare do you think are going to be most impacted by digital health?
So I think that behavioral health is going to be a continued approach. I think the therapies that Rachel and her organization put in place will support lowering the overall cost of care and improving access and compliance. So I think we'll be, as a payer, investing in those types of things. And then the other aspect is, as a payer, we're going to be looking, obviously, and other payers too, how do we bring more care into the home setting? And then also the monitoring. I do think that it will, for us, our plan designs will be omni-channel focused, so we meet our members where they are, and we'll be mindful that we don't disenfranchise anybody because of technology, that we'll have other things available to them so that they can access care where they need to in an equitable manner. And that will be the focus going forward for network health, among others.
Great. Dr. Paulson, what do you think? What's the future of digital health?
Yeah, I mean, I think the future is now. I'm going to double down on this idea of the virtual hybrid model where we pair a virtual team with a care team in the home, and even going a step further, using artificial intelligence to automate the things that don't require a human touch so that we can use that time with the patient and connect more deeply.
Great. And Rachel, we'll give you the last word.
Yeah, I'll try and be super brief. I agree with all of these ladies on the panel. I think therapeutics is going to have quite an impact on our current health system, and kind of embracing tele in-home patient monitoring, I think, is going to be impacted in a big and meaningful way. And I think just overall for the future, closing gaps that we currently have, reducing wasted time, reducing redundancies that are currently occurring in the healthcare space. So I think the future looks good for healthcare and digital health.
Excellent. Well, thank you guys so much. This has been a really great conversation. I wish we had more time, but I really appreciate all the time today and the great conversation. Thanks to our generous sponsors for making this important discussion possible. Thanks to all of you who tuned in. We'll be back in person for Our next Wisconsin Health News event, May 19th in Madison, featuring UW Health CEO, Dr. Alan Kaplan. Hope to see at least some of you there. And thanks again, guys. We'll talk soon.
Thank you.
You.
Bye-bye.